Hello, welcome, and kumusta, and thank you for joining me today. What I would like to share with you in this session is I'd like to share with you some tips on how to do assessment or tips about assessment. And when you're meeting the patient for the first time, some of the pointers that you can use for your practice. Well, tip number one is do not be afraid of the patient. Okay, so at the end of the day, you're a therapist, you're one person, and you're meeting another person for the first time. So there's no need to be afraid of that. So the patient may be sick, they may be ill, they may be attached to a lot of things. As long as you don't do anything yet, you don't tug, you don't pull, okay, there's nothing that you have or that's nothing that you can do that can potentially injure a patient. So tip number one is do not be afraid. Okay, tip number two, it is as straightforward as talking. Think of yourselves as two people having a conversation. Yeah, so that makes it easy and simple. So all it is you're not afraid. You come in, all there is two people having a conversation. Tip number three is be curious. Okay, so you're there when you're assessing somebody, you need to be curious. You don't have to have a list, but it's that normal curiosity. Think of yourself as going to a date professionally, okay? So just get to, or on a party, that's a better way of saying it. So think of yourself as going into a party, and here's this person that you need to talk to, and you need to find out about them, okay? So did I say number three now? So tip number four is be curious about who they are and what do they do and what their day is like throughout the day. So how do they do their shopping, what their hobbies are. Yeah, okay, so that's one way. Or what was their job in the past, and do they have family members? Okay, or do they live in a house or a bungalow? Yeah, so it opens up lots of points of discussion, and when it does, it just makes you pick out the occupational history of the patient. So that is tip number four. So it really falls down on you is, as an occupational therapist, establishing who the person is, seeing the person and meeting the person, and having an overall picture of who the person is. You are trying to get the occupational history, not just of job, but of the person's values, of their interest, what makes them tick, their day-to-day processes, their roles. That's what you do, okay? And then tip number five, so after doing the occupational information, for example, just find out what you want to do is whether is this person, answer yourself, is this person, are the information that they're giving me is reliable? Okay, if it is reliable, then that is good. Yeah, but if it is not, you can just have that casual conversation, because you might be able to pick a few things out of that conversation. And then the next thing that you need to do is then you need to get all of these occupational history and stories to the person, to the next of kin or the significant people who knows the person. Okay, so and is that right to do it without getting consent? I mean, remember, as an occupational therapist, the patient is not just your patient. You know, the patient and their next of kin is a part of your clientele. Okay, so if I'm a doctor, I would only look at the patient, but as an occupational therapist, our patient and our client is the entirety of the patient. So the patient is just half of the equation or a third of the equation, because there might be a few other things or another things that we need to actually factor in. Okay, so that's another tip. So after knowing who the person is, what do they do, what makes them tick, whether they are reliable or not, then the next thing that you need to do, okay, is you need, so that's now you've done the establishment or you've established the occupational history. The next thing now that you need to do, or just be to put it in your mind before you start to move the patient, the next things you need to actually find out what they can do. Okay, so that's another tip. Find out what the patient can do, and you can, now this time there's a chance that you might move the patient. Okay. Before doing that, actually, what you need to do is during the conversation that you're having with the patient, you need to ask the patient, so what is wrong? Find out whether the person knows if something is wrong with them. Okay. So just you need to find out if they have an awareness of the problems. Okay. Them being in the hospital means that there is something not right, and tell them, why are you here? So you need to find out that, so you gauge the insight of the patient. And then, for example, if they're there for a medical reason, the next thing that you need to do is, if the doctors say you can go home, do you anticipate any problems? Do you see any problems if you get sent home now? And then you will then establish some of the concerns of the patient if they have, and if they don't have any concerns, you'll find that out as well. Okay, so there you go. So first is, don't be afraid of talking, get the occupational history, and then the next thing is find out what they feel is wrong. Okay, so they have an insight of things, so that you find out if they have an insight. And then the next thing that you do is, now you need to find out what they can or can't do. Okay, now before you do this, it is helpful to know what the condition is. This is the time where you can actually go and establish, have a look at the person's condition, because every condition there might have an associated precautions to it. Okay, if you are to move a patient, it is then that you need to establish what the conditions are, and you can just look at it in the notes, medical notes, or you can ask the patient, ask the nurses, and then find out. Knowing, you have to be quick in identifying what the precautions are. For example, if somebody has had some hip operations, so hip replacements, then the precautions that would come into your mind would be, okay, what are the precautions after the hip surgery? Okay, so is it weight bearing? Is it non-weight bearing? Okay, so if they are there, for example, with a heart operation and they've had some drains, you can see that there are drains, so you've had that observation. So what are the precautions for that? Okay, you don't tug it, you don't raise the drain above the site where it's being drained at. If there's catheter, you don't pull it. If they're on monitor, for a heart monitor, for example, do you need to make sure that the blood pressure and everything else, is there a precaution? Is there a limit to those things? Okay, with stroke, I mean, false precaution is the one thing. Moving and handling precautions, those are the one thing, things that will make it difficult either for you or for the patient. So after knowing that, so you've established what the precautions are, and then now you need to do what they can and can't do. So the first thing that you do would be establishing your primary concern is their ADLs, or activities of daily living. If they're in the hospitals, or they're definitely not working, leisure is a little bit more put on the side as well. But you can think about the leisure, because you might be able to use that as your treatment. So now is about knowing what they can and can't do. So that is now the physical assessment. And there are 3 ways on how you can actually find out. Okay, so the first thing is, as the patient tells them, is as reported by the patient, so you can find out in that respect. The second one is how it is reported to you by the multidisciplinary team members, particularly the nursing staff or the carers. And then the third one is through a direct physical observation. Okay, so after that, so the person either does it or doesn't do it. And it's now just a matter, if he doesn't do it, then how much level is required with their personal care? Is it special nursing care? Does it need 2 people? Does it need 1 person? Does it need supervision? Does it need setup? Okay, those are the only things. And how does it compare to their previous abilities? Yeah, okay, it's getting a little bit more hefty now. Okay, so you're getting a bigger picture of things. The story is getting bigger. Okay, and the next thing after that, knowing what their another tip would be, if it is difficult for you for the first time, then by all means write down some guiding questions if you want. Okay, because it builds up over time. But if you follow my advice about curiosity, it will just be so simple. Believe me, I have mentioned this and I have tried this with some students who are actually second-year students, and after 2 or 3 weeks, I can leave them establishing baseline of the patients. They are more comfortable, they are more relaxed with patients, and they're able to assess the patients. And they're able to look after the wards, particularly in their assessment. Okay, and then what would be the final point? Yeah, just be comfortable and be relaxed. So these are some of the techniques when you're making an assessment. What you're doing is having a picture of the person, an entire performance history. What you're also doing is trying to find out what is wrong, but don't spend so much time on it. I know it looks very cool that you are acting very scientific and very medical. That seems very cool. But then, if you're spending about 30 minutes in just trying to find out and digging through all the medical history is really a waste of time. So it goes in through with practice, and it will come to a point where all you need is what is the diagnosis, and so you'll have a picture already of what the functional limitations are associated, what the functional limitations are, the functional limitations that are associated with those diagnoses. Okay, what else? Yeah, that's about it. These are some of the tips with regards to making your initial contact with the person. So do not be afraid. Talk to the person. At the end of the day, it's from one person to another. You have to be curious, and it's good because the first meeting is about building a therapeutic relationship. So the initial interview on its own is already the start of intervention, because this is the part where the therapeutic relationship is actually being established. So there you go, guys. These are some of my tips when it comes to assessment and in making that initial assessment with the patient. And these are again some of the pointers that I have obtained and I have learned throughout the years. Again, this is more on some anecdotal tips and pointers. Is mostly discussion or advice that coming from the wisdom of an old clinician to a younger one. Okay, so I hope you learned a little something today. Hopefully this makes your practice a little bit better. Just remember, anything that you do matters and has an outcome. Until next time, bye.